So ours was what are the barriers to clinical teaching, and we'd like to recognize all the groups that came before us with a wonderful list. But a variety of things that I think we all agreed in. Just time, we work in a very busy environment and don't always have time with each patient or either before or after the end of the shift to really kind of fit it in or do so in a way that we feel comfortable doing. Doing so, patient and family are involved or observing. There's the question of fatigue, of course, both from the teacher and the learner, especially with all the decisions we're making on our shifts. Competing priorities, and we talked, there's kind of that patient volume and acuity, both when the volume's too high or when the volume's too low, which is something I think we've all struggled with at times with COVID. Of course, the interruptions, the variability of learner and teacher interest level, identifying knowledge gaps, and then a couple of things just dealing with kind of the fear of teaching, not teaching well, or the fear of the learner not being perfect, not impressing, or getting it wrong, which leads to, of course, emotional reactions. And then there's a really great comment about the subspecialization of our culture, and for instance, distal radius fractures, how we're creating models to do tasks that I don't want to say more senior colleagues, were routine for them, but for my generation and the younger generation aren't as much. So.
Any other comments?
I'm curious, from the learner level, who has a med school that does
These are our guys.
that does clinical experience starting in the first year of med school? Like, we just started that at WashU, and like it creates this huge challenge now. I have like a med student who knows nothing, and I'm supposed to engage in entertainment in the emergency department along with challenging a fourth year and my senior residents. So it's a real challenge.
So I don't know where I did this. I think this was you. We actually we published a short monograph of what to do with students when you don't want to deal with them.
Close your ears. Close your ears.
And it's by year. Like if you have a first year student, this is what you do with them. You send them off to like triage. And there's a whole list of things like you're not going to. It's in academic. It's AEMENT. It's like a download thing. But it actually looks great, and they learn a lot. That's all I would say. So.
Win-win.
Yeah. All right. Cool. Next.
Yes.
All right. So we have what innovative ways to teach have you used, and we're going to ask for help from the audience in a few of these. So the first is a 5-minute sign-out topic. Essentially, this is more of a regimented, maybe less innovative approach of just taking a brief moment of sign-out for dedicated teaching. The deconstructed procedure kit, I think, is super relatable. I think everybody's done that before. Procedure kit that didn't end up getting used. Procedural task trainers. This seems like probably more and more so as there's industrialization. There's money in developing, high fidelity models and that sort of thing. Interprofessional Micro Sim. I think we're looking for help from the audience on that one.
You take one specific aspect of a patient encounter and you do like a huge micro sim for like 3 to 5 minutes on just that with your entire team and just hit that one part of that task.
I still don't understand.
Cool.
Yeah, give an example.
Well, you'll just have to see it come out in print.
No, that's not an acceptable answer.
Well, I think you can take a lot of different forms as well. Like one of the things we'll do is we'll just, if we have a moment, we'll pull an old EKG. I think we all have that caseload of EKGs that we just love, that we're just really intrigued. We'll say, hey, okay, 55-year-old comes in, here at the bottom side, EKG, let's go, 3 to 5 minutes. Work on that, maybe go into a room, have an interprofessional team work together to kind of help manage that patient. What will we do? We just kind of talk about loud and run through that case. You do that about 3 to 5, maybe 10 minutes or so, and then we like to think that kind of sticks and makes it a little more palatable for everybody. It's more fun to teach.
And you can pull in, like the nurses will come.
Yeah, nurses,
and they're all
medics,
based
and
on-
everybody.
Love it.
You do it in the clinical setting too.
Yeah, no, love it.
Role flipping CSI, another one. Somebody want to?
Sorry, I wrote it.
Oh, please.
So going as the mentee or the mentor, the faculty member, and actually goes to the patient first, and then leave out details and make the resident have to figure out what details you left out and how to kind of coach you about some of those important details that you left.
Near peer debrief.
Oh, yeah, I can do
Bedside Education, so this is sort of the idea of two birds with one stone, where we're teaching the patient, but also doing some clinical bedside hands-on teaching with a learner at the same time. I think it mitigates some of the time aspect that we have up there as well. Relay, remind me, what do we have for that?
Relay is, so you start with the junior learner, so they give like their differential and they're not able to get very far. Then it goes to the first, second year kind of works its way up, and then the attending will wrap it up and make sure that they caught it.
It's a nice term for it, because normally it's kind of I love the idea of relays, you're helping each other.
Yeah.
Yeah, it's supposed to pinch until exhaustion.
I like that.
Yeah, and I've seen that done where you get to tag out. So I'm going to start asking you questions when you can't answer, and you start with
You can ask the friends, use a lifeline.
then they pass it off to the second year, who passes it off to the senior. So, but I like relay. That's a good one.
So the ECG reading scavenger hunt was sort of breaking down the pile of ECGs and searching for interesting ones, or having a medical student kind of work through EKGs folded over, I imagine. Practicing on each other, age old, but I think the slit lamp is a particularly good example where we kind of flip roles in the chair. iMeds, like cap identification, and so sort of minutia areas where it's very hands-on, but obviously identifying the type of eye drop by the color of the cap. And then the last, really, probably one of the more innovative ones on here, I guess, is the patient as the educator, when the patient knows more than we do about their disease entity.
All right, so we, to summarize, kind of describing the behaviors of all of our favorite clinical teachers, I think the big one is that we talked about. Some of the big ones were passion to teach and being a humble teacher. I think having passion to teach encompasses kind of a lot of these other ones. Being engaged and learner focused. Those are going to come from caring about it. We talked about can teach on anything. In the ER, you don't get to decide what comes through the door, so an ability to kind of roll with the punches and teach on the clinical cases, as opposed to being a little more narrow-minded and only wanting to teach on kind of what your niche is. And then co-creation of teaching, so kind of utilizing the learners with you as well. And then I think some of the others, just kind of creating an environment that people want to be in when the teaching and learning is taking place. Having people at ease, being relatable, having, the emotional kind of intelligence and awareness to realize that maybe coming out of a really hard code isn't the moment to debrief on what could have gone better. So yeah.
Cool. All right. So this was a gallery walk. How might you use this in your setting? So you're going back to your program. What are you going to do for a gallery walk? New techniques.
One thing you could do is you could have the first group, so let's say you're trying to teach on toxicological emergency, right? You could have the first group write a bunch of things down, and then you could have the other two groups that come back, have to answer specific questions about it. So antigen or pathogen or whatever.
Actually, because you could actually say, put a blank piece of paper and say, put a toxicroom on it. Watch the next one, see if the next one can figure it out.
Yeah.
That might be fun.
That'd be cool.
Yeah. Other ideas? I think also utilizing it in the relay setting would be interesting. Like if you rotate it in a way that you had some of your more junior learners going first, so that it becomes harder, right, as you get to the papers that have more things, whether it was diagnoses or differential or management. By the time your senior learners get to it, 3 other people have already been there. What can they add to? I just think these were all different things, right? And this was a good input kind of in the work. All right, you're up. All right, have a seat. Yes. Questions or comments before we move on? All right. Some of this is net development. Just a net development. You started in this first year.
We don't have a clicker, so.
All right.
No problem. Hi, everybody. Welcome. I think I already introduced myself, but for the people that maybe trickled in, I'm Nicole DiOrio. I work at Virginia Commonwealth University, and one of my particular interests is in coaching. So we're going to hear just a couple minutes about how the technique of coaching can inform your feedback, and in particular, your performance feedback. So quick little didactic here. We're going to go over the model that is not called R2-D2, but I think hopefully I have your attention now, because who doesn't love Star Wars, except maybe Star Trek fans. But anyway, we're going to talk about the model called R2-C2, which I think is a really great technique. Acronyms are my favorite, and it's a great way to think about all the different concepts involved in creating a meaningful feedback interaction, and again, bringing in coaching techniques, which is a particular passion of mine. All right, so what do R2-C2 stand for? So there is, the first R is build relationships. We'll talk more about each of these steps. Explore reactions in the learner, not your own reactions. Confirm content, that's a double C. And then a lot of C's in the last one, but just remember it as coaching. Coaching for change and co-create an action plan. So again, I really like this model because it makes you think more deliberately about all of the steps that are involved in creating a great learning moment. And so it was the folks above that developed this model. And they, I encourage you to take a look at their website, which I believe I have on one of the last slides. They have an entire suite of materials around the R2-C2 model, including a trifold little thing you can keep in your pocket, lots of stimulus videos, all kinds of teaching tools if you want to use this for faculty development. I really encourage you to check it out.
And I'll be emailing out a folder with all this information for you, so you don't have to worry about writing down the whole website.
All right, perfect, thank you. Okay, so the first R is the relationship. So we know that feedback has been described as an educational alliance, right? And the learners need to feel that you are invested in their learning first before they are in a mind space where they can accept feedback, right? So I think this sticky note touched on this. You need to have emotional intelligence, put people at ease, and really invest in the relationship. And sometimes this can be hard in EM, right? Because we may be seeing a learner for the very first time and only seeing them once. So intentionally starting your conversation with this will really go a long way towards putting people in a sort of an open mindset. So you're going to be confirming what you're hearing. Sorry, this is all in the framework of, can you shut that door?
I think it's coming this way, so the microphone's going to be super important.
Okay, sounds good. Well, if you all can hear me, that's the important thing. So this is in the setting of performance feedback, right? So you've just watched the learner do something, and you're coming out to debrief about it. So you'll confirm what you're hearing from the learner, empathize that maybe this was an encounter that went or didn't go a certain way, show respect and validate their feelings. So here's some sample phrases you can have in your back pocket, right? So some of what we go over might be uncomfortable, but I'm here to work through this with you, right? So you're allied, you're on the same team. I remember feeling that way as a resident. So again, this actually touches on some of the concepts that we uncovered over there: humility, relatable, and put people at ease. So be sure to invest just those couple of moments up front, and it'll go far. The second R is exploring reactions. So again, this is the reactions of the learner. I think someone commented, you don't want to immediately come out of a difficult code and then start talking about what they could have done better, right? Take a few moments to understand what that process has just been like for them. Again, this will help cement the relationship, but it'll also help clarify areas going forward. So you're starting to prompt them to sort of process this whole experience that you just observed. Here you can offer your own feedback, and I'm sure you'll be ready to go with a lot of feedback. But by going through this model, you'll resist the temptation to just dump a lot of feedback on them. They may even have sort of process their own area that they want to focus on without you needing to layer on with more telling, right? So some things you could say are, what were your initial reactions? How is this comparing to how you've thought about your performance in the past? The bottom blue box is an example of how you could layer on your own feedback. But again, it's more about soliciting sort of their own reactions first and letting them kind of lead the conversation going forward. All right. All right, so then the next C is content. So here's where you really consolidate where you want to consolidate where you want the conversation to go. So you're kind of hearing how they thought the encounter went, what they might want to take from the encounter. You've possibly layered on some different or confirmatory feedback for them, and then you use this step to get agreement on kind of the take-home points and goals, right? So first of all, you can make sure that there isn't anything that kind of didn't fit into their maybe preconceived idea of themselves or the feedback from you that didn't make sense to them. You encourage them to develop this all into a pattern. Then you kind of align on some agreement for the final stage of the conversation. Is this an area you might want to work on? Now that we've talked about X, what is your goal? So I'm hearing you say this. Let's summarize what we've discussed so far. And then lastly, coach for change. So I could spend hours talking about coaching. I just love it. But if you may need to distill coaching down into two things, it's asking a lot of questions / not telling, asking a lot of questions, and then arriving at a goal. So as you can see, you've already asked a lot of questions in the steps up until now. And so you need to kind of close the encounter with arriving at a goal. You could use a SMART goal. I think most learners are familiar with specific, measurable, achievable, relevant, time-sensitive. You want to push them beyond. I need to be smarter about managing all my patients and be faster, right? So you want to narrow them down into something that's much more specific and help them take those feelings into an organized next step and a goal that they want to commit to. So some questions at the bottom are ways you can help guide them to that final portion of the conversation. All right. What we're going to do next is show a stimulus video.
So we're gonna have you pair off and do a role play. And so I guess before we we'll have you switch. So decide with your people against your friends. Okay. And so decide with your. Let me show you a video performance as proceed. And you're going to provide feedback to that training on this, and then we'll have a break and then we'll go back and okay.
Let me see if I can make this work.
Okay, thanks. I had made that a paper link, but now I don't know where the.
So hopefully this will work. Hey, Jason, no sound.
Do you want me to put the microphone up to the computer?
So, all this whole series, Coursera is like one of those massive online courses, and so this is on the Coursera platform. If you ever want to steal a video, borrow a video, it's a great video, and there's a whole bunch of other ones in there. Both for the purpose, there's feedback, there's entrustment, there's rhymes, stuff, but it's all on Coursera.
All right, I'm just going to start playing. This is a them thing. They've changed their audio to just the microphone.
Okay, let's start back over. We did test this beforehand.
with medicine here.
All right,
Enough, I think. All right, little poke. All right, gonna feel a little bit of pressure here as this one needle goes in. That looks about right. Hold on a second, I'm just gonna use a different needle here. Be done in just a couple minutes. Little pressure. Ow. That kind of hurts. It does hurt a little bit, but you've got numbing medicine. That hurts. Okay, I need you to hold still. That hurts. Hold still. Hold really still. It's hard to do. I'm trying to hold still. Okay, hold still. It'll be done in just a second. Okay, hold still. Okay, I need you to hold still. Is it supposed to hurt this much? Sometimes it hurts some, but you have numbing medicine in there, so don't worry about it. Okay, I'm going to get somebody else.